55X. We're pleased again to have this week with us Leah Binder, who's the president and CEO of the Leapfrog Group. Leah, I'll first introduce the students and what they've learned so far in the course, and then give you a chance to describe your work, and then I think we can jump into some of the questions the students have. So the students so far have had lectures on quality measurement in an international setting, as well as how to think about using administrative claims for quality measurement with talks from the OECD. And this week their focus is on lessons from Alan Kachalia, who's from Brigham Women's Hospital. And Alan's lectures have focused on the roles of accreditation, the medical legal framework, and I think also pertinent for this discussion is the potential impacts of policy efforts around public reporting and incentive programs and how that translates down to hospitals on the ground. So I know the students are very excited to have an expert such as yourself and have the opportunity to engage with you. So I'll turn it over to Leah. It'd be great if you could introduce yourself and talk a little bit about the work that you're doing, because it may be a little bit unfamiliar to the students from the international setting.
Great. Well, thanks so much for having me. It's a real pleasure to be part of this this class and to hear from the students today. My organization is called the Leapfrog Group, which is a kind of a quirky name. We admit that. In the United States, a lot of the healthcare organizations have names that lend themselves to acronyms, like the American Association of Colleges of Nursing or something like that. They all have long acronyms. Well, we didn't want an acronym, so the Leapfrog Group is Leapfrog, and that's it, so it's memorable. But really, our goal was giant leaps forward in the quality and safety of hospitals in the United States. And we were founded back in 2000. We were founded by a group of purchasers of health benefits. So some very large companies like Marriott and Boeing and GE, GM, some very large companies, the executives of those companies, who were spending, in many cases, more money on health benefits than they earned in profits. And they were concerned that that money may not be as well spent as they hoped, that they were very worried that their employees were not getting the kind of quality and safety of care that they deserved. There had been a report that came out from the Institute of Medicine in 1999 in the U.S. that was called "To Err is Human." It's really a important report. I encourage all your students to read it if they haven't had a chance to. And that report said that upwards of 100,000 people were dying every single year from errors, accidents, and injuries that were preventable in American hospitals. And so these executives said, I can't believe that we've been spending all this money on health benefits to try and really improve the lives of our employees, invest in their health, and meanwhile they're dying of these preventable errors. And we don't even know about it. Much less, first they're dying, but also we don't know about it after all this effort we've made to spend so wisely. So so they launched the Leapfrog Group, and one of the things they did was a survey. It's called the Leapfrog Hospital Survey, and it's an annual survey, and they asked hospitals to voluntarily report to Leapfrog on certain indicators of their safety, and now quality as well, but of their safety, and they publicly reported by hospital across the United States. Now, hospitals are asked to report on things that otherwise they're not required to report, but that are very interesting to purchasers and consumers. And the reason that hospitals, in many cases, the reason that they're willing to report to Leapfrog where they may not be willing to make this data public otherwise, is because they're being asked to do so by the largest employer in their community. So really the employers are using the leverage that they have as purchasers to really be persuasive in asking for this data. So when we started out in 2000, about 200 hospitals reported. Today it's over 1,400 hospitals that do report. Still not all of them, and there's over 5,000 hospitals, so we're still looking for more, but 1,500 is a lot, and we're still getting data and reporting data that no one else has. And Leapfrog data is used widely by a whole variety of other entities, such as all the national health plans, a whole variety of entities like many public reporting agencies like Castlight, a whole variety of entities that use Leapfrog and Leapfrog data because it is so valuable to have this kind of information for the public and for pay-for-performance programs, etc. Employers also use the data for their own enrollment programs and for some of their purchasing programs. And then we also launched something 2 years ago that's related but not quite the same as the survey, and that's called the Hospital Safety Score. And that is a letter grade that we assign to all general hospitals, regardless of whether they report to Leapfrog. We assign them a letter grade, an A, B, C, D, or F. It rates them on how safe they are for patients. And we use data from CMS, the agency that funds Medicare in the United States. We use that data plus Leapfrog data if we have it. If we don't have Leapfrog data, we don't use it. And we are able to grade them anyway using other data. They don't get a thumb on the scale for using Leapfrog or not. It doesn't help them or hurt them. And we're able to issue these letter grades, which we think has had a significant impact in the field, at least from what we can see and hear. Many hospitals are very intent on really improving their grade and really keeping their A if they have it. And that's exactly what we're looking for, is really putting some market pressure in the field for an improvement in safety.
That's fantastic, and Leah, we've posted a link to your website as well as where students can access a hospital safety score and look up hospitals from their area. I want to turn to two questions from the students, and it really gets at sort of the founding mission of the Leapfrog Group, and I think it also gets at the difference in the U.S. healthcare system versus the healthcare systems in other countries, where it's mostly publicly financed as opposed to the U.S. where it's mostly privately financed. So the first question is from Dr. Jasvinder, and he asks, what can the private sector, which is rising fast in the health services industry, do to provide the best care to the patients? And then I'll follow that up with a similarly worded question. Unfortunately, I don't have the name of the student, but it asks, it's well understood that U.S. health costs have been spiraling out of control for decades. What's corporate America's responsibility? So let me just kind of reframe those two questions. The Leapfrog Group was not started as a government policy initiative. It wasn't started by hospitals. It was started by a group of employers who wanted to make sure they were getting value for money for the health benefits they're providing to their employees. And that seems like a strange notion, I think, to a lot of our students from other countries, is that these are private companies that are going out and sort of changing the discussion in lots of ways. So can you comment on that and sort of, sort of how that is unique to the American healthcare system, and then if in an alternate world, how you think the lessons from Leapfrog can translate to other healthcare systems which are mostly publicly financed?
Well, I think what is unique to the U.S. healthcare system is this significant dependence on employer purchase of health benefits. I'm not sure it's as unique as is commonly thought. I think there are many countries, like, for example, Brazil, where they have sort of almost two health systems, and one is more employer financed than another. But there's always the sort of public health system that everybody can get into, and then there's another sort of other kind of health system that's more employer financed. There's sort of other models, in other words, in other countries where employer financing does come into the picture and does have a significant influence on healthcare for many people. But in the U.S., until we had the Affordable Care Act, you basically had, if you didn't have employer health coverage and you weren't very poor or elderly, you just didn't have health coverage at all. And so we've just had this patchwork of health coverage, and that's been a problem. We're trying to solve that with the Affordable Care Act, Obamacare it's also called, but and that's coming along, and that's a very important advance for us. But the fabric of our healthcare system and the economy of our healthcare system is truly the employer financing model. So about a third of healthcare spending comes from the employer model. And that's partly employers and partly what the employees spend. And but the largest spender in healthcare is actually consumers. That's the largest group of spenders. And they spend the money either through their copays, or they spend the money through paying directly for a lot of health costs that aren't covered for whatever reason. And so I think what employers have been moving toward as a model for improving the economy of healthcare, so to speak, or how we cut costs, is to give their employees tools to become better consumers of healthcare. So in the past, what employers did, so in the 90s, for example, employers would offer coverage. A lot of them were moving toward managed care or even HMOs, where they offered employees health coverage, and they said, here's the providers that are covered. We'll cover everything. You may pay a copay for this or that, but basically we're covering everything. But under these circumstances, and you have to get pre-approval if you need this surgery or this procedure, and you can't go out of our network. In other words, these are the docs that are covered, and that's it. So they were very prescriptive, in other words. They said, here's where you can go, and here's the terms, but if you adhere to those terms, we'll pay everything. And employees really rebelled. There basically was open public rebellion in the late 90s. People were very upset that they didn't have the level of choice that they wanted among health providers, and they felt that their employers were trying to undermine their health at the expense of in order to cut costs. And it backfired on employers. They did not like it. So anyway, so what they've moved to now is a different model where they say, we're going to open your choices. You can go to more places. In fact, your health is your responsibility. We agree with you. We're not going to try to micromanage your health care. But we want you to be a consumer. We want you to take responsibility for the fact that everything doesn't cost the same, and that choices have to be made based not only on quality but also on pricing. And so what they've been moving toward is high deductible health plans. And what we're seeing right now is a major shift in the kinds of health plans that are being offered by employers. And so most recently there was some data from Kaiser HRET. They do a study every year that showed that something akin to 20% of 1 in 5 workers basically is now covered by what's considered a high deductible health plan coupled with a health savings account of some sort. So people, and these plans have anywhere from $1,200 for an individual to $2,000 for a family and upwards, many as high as $5,000 for a family and $2,500 or more for an individual. That's the deductible, and every service you need underneath that deductible, you pay everything. So you go to the doctor, you're going to pay the whole bill if you haven't satisfied your deductible. So what that does is it changes. All of a sudden you have someone going out there and saying, well, gee, I got to go to the doctor. How much is that going to cost me? You suddenly are pricing out services, and it's just having a fundamental shift in the way people are thinking about their healthcare. So that's one thing that's really changing the market.
Right. It seems like what you're saying is there's, a fundamental part of sort of the American healthcare system is a belief that choice is important.
Right.
And then in order to make the right choice, you need sort of the right information to choose, either based off of costs. And I think the Leapfrog Group has done a great job in terms of providing that information to inform people's choices regarding quality and safety. And I'd like to dive a little bit deeper specifically into sort of the measurement of quality and how we conceptualize safety. And I think this question from one of our students I think is pertinent. It comes from Soraya V. And she asks, I'm paraphrasing this question, is in your experience, how can we benchmark quality and safety in smaller, lower middle income countries that may be isolated without peers for comparison? So to give a little background, Soraya V comes from a nation in the Caribbean, and in her longer post she mentioned that there are relatively few hospitals, so there isn't many hospitals for comparison. And then on a national level, there aren't many other countries that may be similar. So she's trying to get the challenge of sort of how do you find the right partners in order to benchmark to, and how have you thought through those issues?
It's not easy. When we started doing it, first of all, when Leapfrog started doing this in 2000, all we did was we said, well, what would our mother want to know about a hospital? Mm-hmm. I mean, honestly, we had nothing. No one was measuring quality on a national level. So a couple of I wasn't with Leapfrog at the time, but this is the legend I hear. A couple of executives said, well, they certainly want to know if they're managing their prescriptions well. You want to know if the drugs are being handled well. So we now have a standard about whether a hospital has a CPOE system, a computerized physician order entry system. So, I mean, so that's how we started. Now, that's a pretty primitive way to start, I admit. Since then, there's a group called the National Quality Forum, and they existed back in 2000, but they were very, very new. Now they've gotten a lot of momentum, and they're doing a lot of good work. They endorse measures, and so there are a good number of measures of a variety of health measures and outcome. There's both outcome and process measures. And we use NQF endorsed measures as a good source. We also use Joint Commission, which is the accrediting body for hospitals. And there's a number of other federal agencies that we look at. We try to align, in other words, with what's out there in the United States. So I'm not sure what you would use depending from other countries. What we use also as a grounding for our measures is, and this is where there's a lot of lack of comparability with the U.S. and not because the U.S. is behind everyone else, and that is we use ICD-9 codes, and the U.S. still has not moved to ICD-10, which we need to get to because ICD-10 is actually a much richer source of information on quality metrics. So if you have ICD-10 in your country, which most other countries do, that would be a rich place to start. But I guess my advice would be to start by trying to align with other agencies, your public health agency, your accrediting bodies, your hospital regulatory agencies. Those are the kinds of places that we look to. And then NQF, a National Quality Forum here, they have a website, and it's a rich source of information on some good endorsed measures, and I'm certain that there would be some great ideas there as well.
Right. And to explore that point a little bit further, the hospital safety score from Leapfrog assigns a report card. It's an A, B, C, and that's sort of an easy way for consumers to try to understand how a hospital is doing. What are your thoughts? Do you think every hospital can achieve an A, and is that the goal of the quality and patient safety movement? Or is our goal to try to make sure the hospitals are performing at C's are moving up to sort of the average? Let's say it's a B, for example. So is a goal that we try to want to top out every measure, or is our goal to try to move the underperformers to where the average hospital is like?
That's a great question, and I kind of want to say both. And here's the short answer. All of us deserve for every hospital to be an A. The investment we make as consumers in hospital care and the trust that we put in hospitals with our lives and our family's life means that we deserve an A, and they should be giving us an A. In terms of the level of safety that they should be exhibiting. Everybody should be getting an A. Now, that is not even close to where we are as a country. We are the level of safety in the United States anyway is very, very significantly challenged. The data that we see is eyebrow raising, to say the least. CMS put out a report 3 years ago. 1 in 4 people admitted to a hospital suffers some form of harm. 1 in 4. Now, I come from an organization, we represent other industries other than healthcare. That's our purchaser members. 1 in 4 rate of any kind of untoward event is considered catastrophic. It's an unthinkable rate of error or harm or anything for any other industry. So we are so far from everybody being an A. Now, how do we get there? And we think that we would get there by having hospitals compete to get better and better and better and better. And we don't actually know yet what is an A. We think the current A's probably are not, hopefully not, the A's a decade from now. So we have to sort of continue to grade on a curve for a while until we can actually compete so long that we actually push the market to be even better. But right now, there's so much abysmal performance, frankly, that we just got to push that curve.
Right. Some of the students have mentioned this, and this isn't a direct question from the students, but this is a summary of some questions. And it's in the United States, at least, there's been a lot of discussion to kind of carry the benchmarking discussion further. Not all hospitals are the same. You want to compare apples to apples and oranges to oranges. And how that plays out in the United States, at least, is in terms of socioeconomic status. Some hospitals take care of more uninsured patients or patients from different socioeconomic backgrounds, so they may have worse outcomes or different health literacy. And in some ways, it's unfair to compare them to a hospital that may have a very health literate population. And so, what are your thoughts about the role of those socioeconomic factors factoring into Leapfrog's work? And I think and the second follow-up question then would be, how does that then play out internationally? Obviously, not all countries are the same, so how do we compare a very developed country to a developing country where the economic factors are so different, and maybe the disease burden is also different as well?
Well, I think I'm going to answer the question differently for two different factors of that question: quality and safety. So on the issue of safety, as far as I'm concerned, demographic factors are virtually irrelevant. Because, so let me give you an example of some of the safety factors we look at. And again, my expertise is going to be within the United States.
Sure.
So within the United States, we see hospitals that serve the most challenged populations you can possibly serve in the United States. Public hospitals, for example, in the inner city of New York City, getting an A, and they deserve the A. They are very safe. And we are measuring them on things that really they should be able to safely do regardless of who they're doing it to. So objects left in after surgery. Well, it doesn't matter who you're operating on. If they're rich or poor, whatever their color, you don't leave an object in after surgery, right? You have systems in place to avoid that. That's safety. You should wash your hands, no matter who your patient is. So for safety, safety should come first no matter where you are. And safety is accessible, and safety, frankly, is not expensive. Safety is about will and culture and caring about your patients first no matter what. It's fundamentals. It's nuts and bolts of running a first-class operation, and that has nothing to do with investment in money and demographics of your population. Nothing. So safety, demographics don't matter. So that's what we say for safety. Quality is different. So for quality, we do look at demographics. Leapfrog does have measures on our survey that are quality. So, for example, we look at pancreatic surgery. We call it survival predictors. It's an NQF endorsed measure. What's the chances of survival? We do risk adjust for that based on the acuity of the patients that are being operated on. And those measures, again, are endorsed, and so that the adjustment methodologies are endorsed through a variety of experts and stakeholders. And so we do believe in risk adjustment methodologies. However, we do not support risk adjustment based on demographic characteristics. And that has been a big debate, and it remains one here in the United States. Right now it's a major debate within NQF, actually. Here's our take on it. We think that it's really important to measure based on known characteristics. So you should measure quality based on what you know about your patients. And clearly, if a patient is 75, you would measure based on differently their outcome from a surgery than you would measure a 50-year-old. There is differences because of a known characteristic, their age. But that's different than saying, well, one is poor and one is rich. We're making assumptions about what that characteristic means about their health. And those assumptions we don't believe are warranted, nor are they evidence-based in terms of understanding how a particular procedure or a particular condition will affect their outcome. So we think that we should not distort the measurement based on conjecture about somebody's demographic profile. We should measure appropriately, but we understand, however, that it's much there are challenges inherent in serving challenged populations, and that when we look at payment, that's different. So we actually do support efforts to pay, for example, hospitals that are public hospitals or critical access hospitals, hospitals serving exceptionally challenged populations. We do support efforts to pay them at different rates, consistent with the recognition of the populations that they're serving. So payment is different from measurement. We should measure so that we get better and better and not distort the measurement.
And I think that's a really important point, is the difference between payment and measurement, because you have to sort of measure as true to reality as you can, and payment is a matter of policy, and reasonable people can differ in terms of what the right policy is for different situations and different providers or hospitals.
And with measurement, when we do that too, measurement is really important for researchers because we really need to know what is possible. Sometimes we don't know what's possible, but we've seen some public hospitals who have done some extraordinary things and have gotten some excellent outcomes no one would have thought possible until we actually measured it. So measurement is a really important tool for progress and for measuring progress, and we don't want to distort it.
Right. On the issue of measurement, I think there's a lot of concern, both in the U.S. as in international settings, about measurement fatigue. Is we would measure so many different quality metrics, so many different types of safety metrics, and at least in the United States, there's federal penalty programs around value-based purchasing. Private commercial insurers have their own programs, and then there's also other groups like Leapfrog, which measure metrics. And I think a lot of different groups try to align their measures through the NQF, like you've mentioned. But one of our students at Monica NYC asks, during an ARC conference for the other students as the Agency for Healthcare Research and Quality, Brian Sexton said burnout has overtaken the safety culture. That's a barrier for improving patient safety. Do you think there's been measurement fatigue and that's leading to burnout around safety and quality?
Burnout around measurement, around the process of measuring, or burnout around burnout? We hear about a lot, but burnout around measurement.
Yeah, I think it's sort of burnout and around really the measurement fatigue and sort of different measures pulling you in different directions. How do you try to deal with that with Leapfrog Group? Do you what's the right number of measures for Leapfrog?
Yeah, I mean, Leapfrog makes a lot of effort to be aligned with, as I mentioned earlier, with a lot of other organizations, because we do recognize that having too many measures is not conducive to getting hospitals working on what we want them working on, which is achieving the high goals we've set for them, not measuring those goals. I mean, we want them to measure the goals, but the most important thing is that they get to the goals. So we definitely are sympathetic to the problem of having too much measurement and too little actual achievement. Having said that, and by the way, we actually work with the national health plans to really push them on aligning their own measurement, and that's come a long way. They used to have they all used to make up their own measures for absolutely everything, and I think a lot of the national health plans have now gone to aligned measurement, and Leapfrog was a major part of that movement to really push them to align their measurements, and we continue to be. We have something called health plan user groups, in which our purchasers pull together the health plans and grill them on how they're using their measures and are they aligned, etc. So this is a major issue for us. We recognize the importance. Having said that, I think where burnout comes from is when hospitals are reporting and nothing happens. So what I think needs to happen with measures is you report them and then you feel the pressure from the market as a result of what you're reporting. I think because healthcare has so little transparency in reality, I mean, there's a lot of smoke and mirrors about transparency, but there's not really a lot of it in reality. They report the measures and then nothing happens. Like, well, okay, we just put out a really nice report. Maybe it gets put on a bulletin board in the nurses' lounge once in a while, but usually it's just nowhere, and they never hear another word. It's just more paperwork, and that's the end of it. And they put a lot of effort into it, and they feel like nothing happens, or it's not treated seriously, or the board doesn't really care. And certainly, often, it's not made public, and even if it is, sometimes purchasers and insurers don't pay enough attention to it either. I fully admit my own members sometimes don't pay enough attention to the data to really use it. Right. So I think that's why we believe the Leapfrog movement is so important, because we are publicly reporting it. We're among the few, very few. Most hospitals, they just don't have a better way to publicly report it than Leapfrog. I don't actually think that's such a big brag right, to be honest with you. I think there should be more than that in the United States. I think it's kind of sad that we're the only ones, but we are. And that it's really important, I think, that hospitals get that feedback from the market, feedback from their patients, feedback from their own internal communities on how they're doing, and use it to drive improvement. I think that's what will motivate and get past that burnout feeling.
And let's explore that feedback a little bit deeper. And I think one of our students' questions really gets at that. again, I don't have the name because I think it's being submitted live, and it asks, what is the Leapfrog Group doing to hold accountable hospital administrators and medical staff leadership? And I think what the student's getting at is there's a lot of focus on physicians and a lot of concern that there may be, the burnout is really happening among frontline providers, nurses, physicians, and that's sort of impeding the physician-patient relationship in some way. And you had mentioned that one goal of Leapfrog is to use these measures of the public reporting and transparency to let the market sort of correct or highlight sort of the poor performers. But in that, there's a big role of hospital leadership, both the boards as well as the senior administrators. What do what do you think their role should be?
Well, a hospital is not going to be safe if the CEO doesn't think that patient safety is the #1 item on his or her agenda. I'm convinced of that. I believe that unless it's a top priority, it won't happen, because safety requires vigilance, that every single employee pays attention to safety every single minute of every single day. And the only way you can make that happen is leadership has to be vigilant every single minute of every single day. That's the only way it works. And it's an ongoing thing. It can't be just a one-time campaign. Oh, today we're going to be safe, and it's a big campaign. Rah, rah, pop the champagne, we finished. That's another thing. Hospitals do that all the time. You don't finish the safety campaign. So I couldn't agree more that, and in fact, Shisha has often stated, I'm waiting to hear about the CEO who was fired because the hospital wasn't safe.
Right.
That, and you're right, that I don't see that happening. Now, Leapfrog's not affiliated with hospitals. We rate them. We don't claim to have any expertise on how to run a hospital. We're very deliberately not involved in the actual management of a hospital. We have no financial stake in hospitals. We don't charge them to do our survey. We're very carefully segregated from hospitals because we rate them. We want to be absolutely, we want to have full integrity in our rating system. So we are the market push from the outside. What I would like to see is more physicians and more nurses, particularly, but also pharmacists and everybody else who works in the hospital, pushing from the inside. And I think they do, but we just don't necessarily always hear about it from our vantage point. Pushing from the inside, saying, why did our hospital get a C? And going to the board and going to the administrative leadership and not allowing them to use the same tired excuses that we hear all the time. Well, something's wrong with the measurement, or Leapfrog something, this and that. I mean, Leapfrog's integrity is simply unquestioned. I mean, the U.S. We just have every major expert who's ever looked at patient safety really endorses Leapfrog. They know that we are. Whatever you may think of the transparency agenda of Leapfrog, you understand the scientific integrity of what Leapfrog's doing. So there's this grumbling and this try to kill the messenger, and I'd like to see the physicians and the nurses really stand up and say, you know what, it's time for us to look at ourselves and let's push on this, and use that external market leverage as a tool for them to push from the inside. And we are more than happy to work with anyone who wants to do that. That's what we hope will happen more and more. And we do hear anecdotally, by the way, that is happening. We had one hospital, which was a very big name hospital, that we gave it a very low grade to, and they deserved it. Their data was very disturbing. And what I heard from a couple of people who I know over there is that the board called in the management team and ordered a top-down review of their safety program immediately. And it really launched a full-scale upheaval. And they've improved. They're still not there yet, but they've definitely improved. So that's what we want to see. We just want to see, we just want to jolt action. We don't claim to make action. We want to jolt it. And we hope that we're helpful to those internally who need that kind of external pressure.
Right. And to sort of tie both the students' questions together, it appears to me in some ways an appropriate response to the concern around burnout and measurement fatigue is to give the frontline providers a sense that they have skin in the game, and that these measures are meaningful clinical metrics and not just sort of arbitrary measurement from outside groups, and that everybody, the Leapfrog, the hospitals, the providers, the patients are all sort of part of the same agenda, which is, I think, something that everybody can agree on, which is improving the quality of healthcare delivery.
And I think there's a lot of measures that are frankly boring. And
Right.
and so that has to do with, there's a little thing here in Washington, D.C., which, Tom, you may know a little bit about. It's something we call politics.
A little bit.
A little bit of that. So, and there's a lot of politics to this measurement here in the United States, a lot of politics. And the politics is really around making the measures, less controversial, or so that they don't gore too many oxen, basically. So somebody, doesn't get singled out as not being very
So
good.
everybody, is the best, and everybody has an A on their safety score.
We don't, yeah, right. So that's why Leapfrog is, by removing ourselves from the sort of multi-stakeholder politics, we are
Right.
able to give D's and F's. But if we were in the political environment, that would work. And so another example of that is CMS, which is the agency that funds Medicare. They do publicly report measures as well, which is on a site called Hospital Compare. And on that site, that's supposed to be for consumers. And by the way, to their credit, they are very transparent behind Hospital Compare. So there's lots of information that you can get, like Leapfrog can get. So I give them credit for that. But the consumer-facing site, if you want to find out about how hospitals are doing, it basically rates all the hospitals as average. 90% of them are average. And then the other there's like 5% that are above average and 5% that are below average. So that's not helpful to you as a consumer if you're actually trying to choose among hospitals, if they're all basically the same. And they're not all the same, and we know that about hospitals. So, but that's the politics, and that's how it kind of plays out. And I forgot why I brought up the politics issue, but the politics of measure. Oh, it's why it's why the measures end up boring.
Right.
So we end up with a lot of boring process measures. When were antibiotics administered before the last dose of something before surgery? And I imagine that must be a burnout factor for a lot of people in hospitals. Like, why do I have to collect this boring measure that we look good on anyway, but everybody looks good on? And, and frankly, we at Leapfrog aren't going to use it. Purchasers don't care. Consumers don't care. Your mother doesn't care. Nobody cares.
I think that's the important thing we should all return to. Like what you started the conversation with is,
Yeah.
what does your mother or your grandmother care when they want to go choose a hospital or a doctor?
Exactly. So we look for sexy measures at Leapfrog. We're looking for good measures, really, and I don't mean that in a pejorative way. I mean that we're looking for measures that matter. Am I going to die from this surgery? Am I going to survive it or die? That matters. That matters a lot. Am I going to get an infection? Are you going to make a terrible error during my surgery? I mean, those things really matter. Have you put in place what you're supposed to have in place to prevent me from being harmed? And so, we look for measures like that, and I think that's what's got to be motivating because I know there's a lot of hospitals that actually really get involved and really are supporters of Leapfrog movement and actually get very motivated by Leapfrog, and I think that's part of it, is just feeling like these really matter and they're really used, and I think that's the key to getting past that burnout.
And this leads us to a related issue in terms of sort of the more blunt, where everybody performs well sort of measures versus sort of measures that actually segment out variation in performance. And one of our students asks, this is at Dr. SR, what do you think are the indicators that are needed as an absolute minimum to ensure high quality care? And I think this, and to kind of relate this to some of the coursework the lectures the students have been listening to, they've been learning about accreditation, so sort of minimal requirements, mostly around structure and some around process that hospitals need in order to be licensed at the United States and in lots of other countries as well. So this tension between the bland measures, which may be used for accreditation, and the more controversial measures, if you will, that actually show more variation. How do you think that how do you think those two different types of measures play in? Should the process measures then be used for accreditation, sort of minimal standards, and then what we really differentiate in terms of transparency and choice is then on the outcomes measures for say?
I'm not the biggest fan of process measures in general. I think they're helpful for quality improvement. I would say obviously they are. They give you a very direct checklist of what you're supposed to be doing, and that's great, and I think that's why they're valuable, and I support them for that reason, because I do think that's fair. I mean, you should be given a list of processes that you ought to be engaged in, but I'm not the biggest fan of them in terms of for my own use as a consumer or purchaser. And we use them though. I mean, that's the majority of measures that we have, frankly, are process measures, unfortunately. Back to that politics, and as well as just simply the field itself hasn't advanced enough to get us enough outcome measures. But right now, I'm not the biggest fan of process. But I think to get to the question about what would be the sort of minimal standards that I would look for in a hospital, I would say, given that measurement science is at its infancy, and in some respects we don't even know how well a hospital could do, we don't actually know what the possibility is. So I wouldn't say an outcome measure would be my minimal standard, because I don't know if 10 years from now that will seem laughable and that will seem like a terrible hospital. That actually 10 years from now we can do so much better than that. So I would be looking for that for structural measures. And that's it's sort of my gut, because that is, if I walk into a hospital, the first thing I'm looking for are certain structural measures. Do they have a EMR that all the docs aren't complaining about? So that's about 1% of hospitals, I would say, right now. Do they have computerized prescriber order entry? That will cut medication errors by 75%, but is it working? Leapfrog has a test to see if it works or not, and a lot of times they actually don't work very well in terms of decision support, so that's another percentage of hospitals, probably about a third. Do they have sinks and hand hygiene easily accessible in the rooms? Look for that. So you look for, do they seem to have a culture of safety? Are they kind to the patients? There are structural elements you can actually see in a hospital. Sometimes they're just visible, or they're reported intensivist coverage in the ICU, things like that. So I guess I would turn to structural measures as a minimum standard.
Right.
And I think those can be measured.
And to tie some of those thoughts, I think you've done a great job summarizing our previous several weeks' lectures. So we had David Bates in the first week talk about medication safety, and I think you sort of just contextualized it very well, and how that then translates into measurement and public reporting to kind of help patients ultimately, choose the right hospitals that follow these metrics. So that was actually a nice summary of our journey over the last several weeks of global safety and quality. I'm going to turn back to some of the questions again from the students and explore some of these issues further. And I think this is interesting and is relevant to a lot of the changing healthcare system in the United States. At Carolina Santos 7 asks, how can we find an effective balance on these issues to somehow tip the scale to health management rather than disease management across all population groups? Any thoughts about that, and sort of thinking more about health and not just sort of disease?
Yeah, that's a big issue here in the United States. That is the issue. There is the movement toward ACOs. I'm sure your class has talked about accountable care organizations and that sort of movement, and generally value-based purchasing, which is another generalized movement, which in many respects is exactly about that, which is moving toward thinking about the whole patient, not just that person who's within the four walls of your institution at this moment, but this human being who lives in the community and is part of the population, and thinking about the health system and us as part of it as having a responsibility for the overall health of the population. That's just a real shift in the way we're thinking about the responsibility of our health system, and it's a shift in the way purchasers, my members, are thinking about their responsibilities. One of the things we've seen a big shift in with employers is that virtually all large employers right now offer some kind of wellness program. So smoking cessation classes, or health coaches, or care management programs, some kind of program in addition to their health benefits, so their insurance coverage, they're offering these wellness programs, again with this sense that they have a responsibility beyond sickness care or caring for the conditions that might go, the things that might go wrong, but to really help employees maximize their health. So there's definitely a shift in thinking. I think there's a lot of questions about what works. Rand just put out I think it was kind of not a meta-analysis, but an overview of some of the research around wellness programs, and found basically no impact the ones that they could observe. And I think that ACOs are a brand new idea. No one's even defined what. There are all kinds of different ones. I mean, it's hard to know at this point what the shape of all this is going to be like. But I definitely think it's encouraging that we are seeing this, because it really does make sense that we think about our health as more than just our sickness. And the other thing that's driving that too is there's now very significant incentives and penalties on hospitals that cannot reduce their readmission rates through Medicare. And that's driving a change in the way hospitals think about their responsibility to the whole patient. All of a sudden, it matters what happens when their patients walk out the door and what go into the community, and it suddenly matters that that they have nowhere to go, or they're not adhering to their medications, or they don't have a primary care doctor, or there's no social supports. That matters to the hospital in a very significant financial way. And financial, unfortunately, does drive sometimes a lot of action. So I think that we are seeing that shift. I'm not sure where it's going to go. I don't think we've seen actual achievement of anything at this point, to be honest with you. But I think that that is a shift in our thinking.
In that answer, you had mentioned the perspective of your members, and it just occurred to me as you were explaining that a lot of your members are actually very, very big employers, and they employ employees not just in the United States, but in other countries as well. And how have they thought about sort of providing the same level of transparency and focus on healthcare quality for their employees in terms of their access to healthcare in other countries besides the United States? Are there thoughts of expanding the metrics sort of more universally, or rather the philosophy of the Leapfrog Group more universally? Or are the employers thinking about collaborating with local partners to offer the same level of robustness and objectivity of data for their employees?
I mean, I think there's always been some interest by a number of our members in figuring out how they could do a similar initiative to Leapfrog in other countries, but each of our employers kind of has a different level of presence in different countries. There hasn't been the same level of ability to sort of come together and leverage together the way Leapfrog is, because Leapfrog really ultimately represents hundreds of purchasers, so we haven't had the same ability to come together as one unified voice in any one additional country. But there's always been a lot of interest on our board in figuring out how we might be able to do that. I know the companies that are involved in Leapfrog are always interested in figuring out how they can address this issue of transparency and improving health across the globe for what they're doing. So I think if any of your students are interested, that we certainly would welcome discussions on how we might be able to move that along.
One thing I've really liked from the discussion so far, and it was in your previous answer, was a sense of responsibility, the readmissions measures has forced hospitals to take responsibilities over the patients after they've left the hospital. So can you explore that a little bit more, and how can we sort of spread that sense of responsibility throughout the healthcare system? Is there a way for you to use quality measurement, like the readmissions, to sort of spread that, or are there other ways to do it?
I think that one thing that we would like to see is sort of a different approach than kind of trying to force hospitals and health systems to take care of patients, sort of a top-down approach. We'd like to empower consumers to use the tools that are available to them to make sure that they get what they need to manage their family's health. And that's just a kind of a different approach than the top-down approach, and I think that's more of the purchaser's approach. So let me give you an example. If you're discharged from the hospital, you feel like you're on your own. You have a prescription, you may not know what it's about, you don't know who to call, you go home, you might be given a device, you don't know how to work it, you can't get an appointment with your doctor, you can't, you have all these issues. So you want the health system to work to your advantage. So you can be very specific. I want to make one phone call, or I want to have somebody come over to my house and take care of this one thing. But we want it to be driven by what that person needs. So I think what a lot of successful entrepreneurs are now doing is meeting that demand from that patient, starting with that patient. And so I'm thinking of, for example, CVS and some of the chain drugstores are now opening their own clinics. And they're doing that because people wanted a place they could go off hours or anytime and just go in and quickly get a prescription filled, or not a prescription, but quickly get an appointment and get seen for something. Or it's meeting a patient demand that the rest of the health system has been unable to meet. So we're starting to see more entrepreneurship of people who are meeting that patient demand. I think what employers want to see is that same thing. They want to see their begin with what my employees need and start to actually build a health system right around that, as opposed to saying to the health system, here's all the things I need you to do right now. We want to actually say to them, here's the patient, and if you can't meet their demands, then you aren't going to be in business long. We need you to compete to meet their demands.
And I agree 100%. And there's a great question from one of our students that just came up, and I think it really follows up on focusing on the demand of the patient. And Amma B asks, in regards to measuring the provider-client relationship, how do you measure patient satisfaction or get information on patient experience? And then I'm going to push a little bit further and say, is patient satisfaction part of quality of care?
It really is, and we're not doing a great job of measuring it. I have to say, we have a measure called HCAHPS, which is done by I think it's CMS, that requires hospitals to measure patient experience in the hospital. They send out a form. It goes out like 30 days after someone, a Medicare beneficiary, is discharged from the hospital. It's a paper form, and they have to mail it back in what we call snail mail, the U.S. Post Office, which nobody uses anywhere. And so they get maybe 3% response rate, which I think is high, because I don't even know where to buy a stamp anymore. But anyway, so they send these out, and it's not real time, and it's a set of questions that are approved, and there are certain categories. I think we need to start to use technology to get us real-time information. Why can't you be in a hospital bed, and why can't you use your smartphone to give real-time information about the fact that you're in pain or discomfort, and they haven't been responding, or you have this feedback about this or that. I mean, or you've had this complication, or if we could get real-time feedback from patients, I think that would drive an incredible improvement in the system. And we have not done that yet, and I think there's a real call for it. I think that's the next big wave of change in the healthcare system, is going to be this drive to use technology that we have to try and get patient feedback as central to quality measurement.
I agree completely, and keep an eye on the time. Our time is coming to a close, but I think that's a great place to end, because that's a nice clarion call or challenge to our students to kind of focus really on patient satisfaction and thinking critically in their coursework and in their clinical work and their research, to think about how we can really focus on the consumer, on the patient, and on the satisfaction and the demands of the patient. And again, to go back to what Leah had said at the very beginning, focusing on the questions that really matter. If you're, what would your mom would want to know if you're choosing a doctor or choosing a hospital? So I think that's a great place to end our wonderful discussion so far. And actually, week 8 of our course, we have a whole section talking about the challenges and opportunities of measuring patient satisfaction. Leah, on behalf of Ashish Jha and the hundreds and thousands of students in this course from all over the world, just want to thank you for taking time out of your busy schedule to share your lessons and your thoughts with us. And I think there's we've definitely important pearls of wisdom that you've left with us, and we look forward to carrying this conversation further in the remaining weeks of our course. Thank you, Leah.
Thank you for having me.